When we talk about metastatic prostate cancer, there's a disease spectrum, and that's been alluded to with a nice study talking about PET imaging. You can have one retroperitoneal lymph node that shows up, you can have an isolated bone met, or you can have what is traditionally thought of as widespread bony metastases. We know from the pioneering work that was done many years ago now that prostate cancer is almost always initially responsive to the androgens, that depriving androgens usually results in a regression of the cancer, and this is a backbone for our therapy. More common in our case presentations probably, but certainly we see patients that don't respond to hormonal therapy in general, and so about 90% of tumors do, but some do not, and even though they do respond initially, they'll ultimately progress. There'll be over 33,000 cases of prostate cancer deaths in the United States this year alone, so we certainly haven't won the war yet. We know that extent of disease is an important component of of how they'll respond to therapy, and I wonder if Dr. Crawford's original study in the New England Journal was presented at the very first meeting that they had here 30 years ago. But certainly he and others have noted in studies looking at it was more the extent of disease that impacted their outcomes rather than the treatment, whether it was combination treatment or not. And so current definitions for high volume disease are out there, and a lot of people are sort of adopting the CHAARTED definition. If you have visceral disease or 4 or more bone metastases and at least one outside the mainframe, then those are considered to be high volume. We know there are various treatment strategies. All of them are backboned on some form of androgen deprivation therapy, but none of these therapies alone are enough. And so if we could compartmentalize them into strategies, we have chemo-hormonal therapy and then more potent androgen axis therapy, and that's what I'll briefly summarize. The CHAARTED study was the first study that really showed the advancement of adding docetaxel to ADT in a randomized form, and they did use that a priori definition of high and low volume, and for all patients there was about a 1-year overall survival benefit, and most pronounced, almost 18 months in patients with high volume disease, and little benefit in those with low volume. They extended their survival by a couple of years and found that their initial findings held up over time. And again, this added a move forward in the field for use of chemotherapy. A companion study from STAMPEDE also showed in a similar trial design that there was improvement with the addition of docetaxel in men with metastatic disease. But I'm sorry this has to be sort of pirated from abstract because it's not published yet, but they presented a 3-year follow-up on the STAMPEDE study at the ESMO this year, and by adding 3 years of additional follow-up and targeting that low volume, high volume specifically, they actually found that patients in their study benefit whether they had low or high volume disease. In fact, the benefit was probably biggest in those patients who presented with low burden or low volume metastases, and that held for failure-free, progression-free, and overall survival. No one really knows why there's such a discrepancy, but it's been postulated that because so many of the people in STAMPEDE, about 95%, presented with metastatic disease de novo, that might explain why they were so responsive, whereas a lot of the patients in the U.S. study progressed through prior local treatments. The maximum androgen ablation story was demonstrated in these 2 back-to-back New England Journal publications looking at the value of use of abiraterone in men in addition to ADT. So the Latitude study had over 1,000 men, and by combining abiraterone with ADT, there was a significant reduction in both radiographic and risk of death from disease. And then the STAMPEDE study, which of course had a version of this, almost 2,000 men, was confirmatory in that there was a significant improvement in overall survival by adding more potent androgen axis inhibitor to ADT alone. Now we're moving into an era where anti-androgens are also being seen to show similar benefit, and so this was the New England Journal publication for apalutamide. The Titan study had over 1,000 men in this study, and again, simply by adding a more potent anti-androgen, they were able to show significant radiographic progression-free as well as reduction in death from disease, and these are their survival curves. Interestingly, in this study, low and high volume disease and prior docetaxel therapy were also shown to be responsive. Enzalutamide had 2 studies that have come forward in the last year, and the first one was the ARCHES study, and the ARCHES study added enzalutamide ADT and was powered for radiographic progression-free survival, and again showed a benefit. I'll show you just that there was for low and high volume disease as well as prior docetaxel, all showing benefit. And then the ENZAMET study, which was the second enzalutamide study, showed again overall survival, not just radiographic progression-free survival. And in this study, at least, there was better benefit in patients with lower volume disease and no prior docetaxel. So I tried to summarize the changing landscape for metastatic prostate cancer. This is seen in the NCCN. The AUAs are revising their guidelines to encompass advanced prostate cancer as well as CRPC, and that'll be coming out in the spring. But I think it's helpful for us as clinicians to kind of think about these various treatments, and really most men should be offered something in addition to ADT alone when it comes to newly diagnosed metastatic disease. In the time that I've allotted left, I'll just briefly touch on the oligometastatic prostate cancer population. And we see the men with this low volume metastatic burden on here, and this shows you kind of where they're positioned in terms of their disease burden and also where they fit as we head towards that lethal form of prostate cancer, CRPC. Worldwide, over 1 million men with prostate cancer, about 20% are thought to be metastatic. It's hard to get the numbers on oligometastatic disease because of the changing imaging modalities like Dr. Ryder showed, but we know that we'll be increasingly finding more men with what we would consider small volume metastatic disease, and we believe that these patients, compared to patients who present with more extensive disease, have a better response to therapy and derived from some of the other tumor types like GI tumors, for example, lung cancer. There is benefit proven by treating the primary tumors and some of these metastatic sites in terms of improving their overall survival. So it's a very attractive thing. But it's relatively new to urologists. And I think somebody mentioned the cart before the horse. So this one is, if the horse is out of the barn, you might as well figure out how to saddle it. So that's kind of the concept behind these treatments for oligometastatic disease. This is a summary of some of the definitions that are out there, because there really isn't a standard definition yet. But you can see that most of the studies, although using different forms of imaging, consider somewhere between 3 and 5 metastases sites. Most of them are bone or lymph node, but there is no really truly established definition yet. But it's rather a variety of these things, but you kind of know it when you see it. What are the pillars of therapy? Well, I just went over some of the systemic therapy, and that is certainly the number one pillar, but these metastases-directed ablative therapies and then treatment of the primary site in men who've never had treatment are certainly all part of what is thought to be the approaches, with goals to delay systemic therapy if possible, and improve quality of life, and possibly even add survival benefit. So it was already shown a few minutes ago, the STAMP trial. It's a relatively small study, only 62 patients, but it was a phase 2, if you will, randomized study, but what they showed was by treating the low volume metastatic sites with radiation therapy, they were able to delay the use of systemic therapy. And then there was a similar a study called ORIOL, which was also oligometastatic, where they showed some delay in progression by about 6 months in favor of the stereotactic ablative therapy. You can see that in summary from some of these treatments that are directed stereotactically at the low volume metastases. First of all, the number of patients in each of these studies is relatively small. that the number of lesions treated is usually 3 or fewer, that the lesion control by about 2-year follow-up is actually quite good, greater than 95%, and that overall these therapies could be delivered in a low toxicity type of environment. So ablative therapies such as these stereotactic directed show minimal toxicity and excellent local control, and there's insufficient data currently to really, in prostate at least, determine the ultimate impact on their survival. What about treating the primary? And this is just the last little bit I have here. There have been 2 radiation trials that have been shown to potentially add benefit to men if we treat their primary in the setting of metastatic disease. The HORAD trial, which did not show overall survival benefit, but it did delay PSA progression in the patients treated with radiation. I'll show you that in a minute. And then there was a STAMPEDE trial that also looked at this, and again did not show overall survival benefit, but in a subset of patients that had the CHAARTED definition of low volume disease, there was survival benefit to radiation therapy to the prostate primary. So the HORAD trial, again, I mentioned that was the first one. It showed some progression-free and gave a little credence. They had a subset of patients with low volume disease, but I didn't include it in the time I had allotted, but it sort of set the stage. And then the better study was the STAMPEDE study, which randomized men, and again did not show in those with metastatic disease an overall survival benefit by adding radiation to the primary, but there was an improvement in failure-free survival. And then when they subsetted it out for those low volume patients, based on CHAARTED definition, they did see improvement, which included overall survival benefit in those men. This is an active area of investigation, so these are 3 of the clinical trials that are ongoing, looking at the role of surgery, because we're also interested in local control with surgery in the right patient population. And in the United States, the Southwest Oncology Group study is the one that we're enrolling patients in. And what they do is they get 6 months of systemic therapy, and then at the end of, nearing the end of that 6 months, they're randomized to treatment or not, and then within treatment, they decide whether they're going to do radiation or surgery. The clinicians and the patients decide that. So it's not just a surgical study, but it is the only one in the U.S. that I'm aware of that's looking at the role of surgery as a primary treatment in men with metastatic disease. So the take-home messages for this are that this is a rapidly evolving field, and we certainly saw the changes come forward when it came to chemotherapy. Now we're seeing additional benefit, not just to abiraterone, but some of the other oral agents that are the androgen blockers. And we know that chemo-hormonal therapy improves survival in men. We were thinking more towards the high volume only, but I think that's going to have to be reassessed now that it seems like men with low volume disease can benefit. More potent androgen targeting was highlighted and it benefits patients with both low and high volume disease. And I think the future will be finding better ways to predict who will benefit from these, not just things like are they de novo or have they progressed, but actually some sort of a molecular profile. And then in terms of oligometastatic disease, it's a new paradigm for us, but I think that we're going to have to embrace it because there's likely going to be benefit for our patients. Best systemic therapy is kind of a backbone. The role of radiation therapy, both directed at the small volume metastatic sites as well as the primary, is already a standard, and the role of surgery is investigational. And so with that, I think I'll end my talk a little ahead of time.